He'll have to wait. Well, good afternoon. Good to see everybody. I'm going to just try to make no slides, no standing up, unless I change my mind about that. Four simple points, and then maybe a series of slightly more complex points. But I think you'll all be able to follow it more better than even I'll be able to say it. I think the first point to make is if we step back and look at where we are in healthcare, what it means is, and I'll quote Atul Gawande, who says that life today is a series of accumulation of chronic conditions. Life 50 years ago, 75 years ago, 100 years ago used to be you get sick and you pray that you would be getting better, and if you didn't, then that was the end of the story. And you had a healthcare system that was set up to meet acute needs, and certainly some primary care. But that was fundamentally it. Today, thanks to modern medicine, thanks to technology, thanks to great cures, we're living longer. But what that means is, in effect, we're just, over time, success looks like piling one chronic condition on top of another because we survived them. That's not a bug. That's a feature. That's a good thing. So come back to, we are going to need a system that acknowledges that. Secondly, people can't afford to get sick today in this country. I was on a panel with the president of the American Cancer Society. They run a hotline, the American Cancer Society, that people call when they get cancer. The number one call they receive is the following: I can't afford to have cancer. And indeed, within 2 years, 40% of people diagnosed with cancer spend through their life savings. We know that, thanks to the great work at Kaiser, is that 1 in 4 Americans say they can't afford their prescriptions. I think about that every time I'm in a pharmacy. And I think about some man or some woman who will go up to the pharmacy counter in line before or after me, get the price of the prescription, and then do what? Slowly and shamefully back out of the pharmacy. And then what are they going to tell their family? Honey, don't worry, I've got some aspirin. They were out. We'll get it from a friend. Or if it's for themselves, probably do nothing. The third point is, some people really can't afford to get sick. Some of us, we're fine, but we are afflicted by this horrible problem in healthcare measurement called averages. And we lull ourselves into our understanding of how we're doing. Let me give you one example: maternal mortality. If you look at maternal mortality in this country and compare it to other countries, and you looked at our average, you'd say we're doing poorly. You'd say we're doing poorly because you'd compare us to other developed countries, and we're last compared to other developed countries. That's poor. But if you looked at maternal mortality among black women, you would say we're doing as poorly as any country in the world. We're not doing poorly, we're doing horribly. But if we focus on the averages, not only do we miss the problem, but we miss the opportunity to focus our solutions. And so we create a system that treats the average, and which means we do a pretty horrible job of treating the people who really need it. We have zip codes in this country that are 8 miles apart, Trenton, New Jersey, Princeton, New Jersey, that have 12-year difference in life expectancy. So we know that this happens because of a variety of reasons. We know that there's a lot of social factors. We also, if we're honest about it, know that we have our own biases in how we treat people in the system. Until we start moving away from averages and start focusing on what does the worst care in our institution look like and how does that compare to the average and how does that compare to the best care, we'll miss it, and we'll miss targeting our solutions in the right way. So social determinants of health has become a really big buzzword, and I think that's great because every healthcare phrase deserves its 2 years in the sun of being a buzzword. But this really is a root cause. I'm fond of asking people, slightly meaningly and cynically, do you do work in the social determinants of health? And if you ask people, what do you expect to say? Well, yeah, of course. And they'll tell you about how they bring non-emergency transport services to their hospital and so forth. But if you then ask them, do you do anything to combat structural poverty and racism? They'll say, oh, no, that's not our job. So fundamentally, I think we're creating the surface image of a couple things we can do, and that's fine. I had a conversation with two hospital system CEOs, both great people doing great work. One of them said quite proudly, we provide non-emergency transportation to anybody who needs to come to our hospital. And the other one said, we provide transportation to take people to church. And what I think was interesting about that, of course, is it asks ourselves to reimagine our role a little bit. Because if you're really thinking about, what is our role in the community? Well, it's to take care of when they're sick. Well, no, maybe we can keep them healthy. Well, no, actually, maybe we can play some sort of more central role in a community that focuses on some of these other issues and get further and further upstream. So it'll be exciting to see what happens there. Fourth point is, what does success mean? What are we aiming at here at this point in time, given some of the things that we just talked about? Well, first of all, success doesn't mean the same thing to everybody. It's amazing when you really listen to people, and we do a lot of polling, and we do a lot of conversations with people, as Kaiser does, but when you don't listen to people to try to prove a point, but when you listen to try to understand, it's amazing the diversity of issues, but that all add up to basically the same fundamental concern, which is people want one thing. If you strip away all the buzzwords, people want to be able to afford to take care of their family if someone gets sick. And they just want to afford to be able to keep them healthy. That's all they want. That's all they want. And when they can't do that, it's an existential crisis because you don't feel like an adequate parent and you don't feel like you could capably lead a middle-class life when you don't have the ability to do that fundamental thing. And when someone threatens that, whether it's an insurance company's fine print, an administration, a Congress, a judge, or anybody, that threat is an existential threat to people. And I think we've seen why healthcare has become not just a life and death issue for people, but quite a big pocketbook issue. So I can tell you that the stories that I've seen about what does success mean to somebody, for a family with a child who lives in severe pain, what does success look like? Success looks like several days free of pain. It looks like maybe getting a shower every couple of days. It looks like a day in the park. It looks like some fundamental opportunities that were represented in your last slide. To a working mom, divorced, kids, success looks like letting their kids play sports in school without worrying that they're going to get sick or injured and they won't be able to pay the medical bill. So healthcare is actually the underpinning of our ability to live a middle-class life. And so in all of the things we achieve, this is really important. So as I think about now, I'm going to get to my last point, which is a series of more complex points, which is, okay, how do we finance all of this? How do we do all of this? What's the structure for this? And I'm struck by a conversation I had, former Australian Prime Minister, who said to me, and I liked comparing ourselves to Australia. I think we need to do that more and more because every time someone compares ourselves to someone in Northern Europe, we get accused of being pansies and socialists and all that. But Australians are outdoors people. They're swashbucklers. We admire them. They admire us. We want to be like them. And they have a pretty good healthcare system. And he said, we love Americans. We love you. We think you're great. There's a couple things we just don't understand. One of them is you seem to want to leave your citizens in kind of a state of what he called quiet desperation. And what reflected on was, when you think about it, very few people actually know for sure that if something horrible happens, they'll be able to pay for it, whether we're insured or not insured. Now, he said, look, we don't do everything, We just try to take the basics off the table so people can go about their lives. We kind of wonder why you don't do that. I thought that was interesting. But a couple of principles I think about when I think about how we structure and pay for our healthcare system. One is if you're healthy, you can work. You shouldn't have to work in order to be able to get healthy. Second, the more we can have our dollars connected to the care of a patient, the better. The more we have things like pools, block grants, things like that, the more disassociated the money in the healthcare system is from the treatment, the less accountability is going to even matter. The less value-based care will be so cheapened and dumbed down because all of these other dollars. Third, we can't let insurers decide who gets covered and what gets covered. They don't want that responsibility, by the way. This is not a pro-government, anti-government point. They want a set of rules that they can follow. And so this notion that we as Americans are accumulating a set of chronic conditions that we can allow kind of a Wild West set of decisions on what is covered, how much is covered, and so forth, doesn't seem to fit where we're going. We have to be thoughtful about how work and benefits are connected. By some studies, 90% of new jobs don't come with health insurance. Those that do today, on average, people spend 30% of their salaries on their premiums before their deductibles start. I think we have to have some thoughts on what are reasonable measures of patient responsibility. And there's room for argument and discussion here. Bernie Sanders would say patient responsibility ought to be $0. Some would say, and some reality for many is $6,000 or $8,000 deductible for someone who's making, $30,000, $40,000, $50,000 a year and has several kids. There's probably an answer somewhere in between $0 and $6,000 or $8,000. We probably have to make a series of tough decisions. And to do that, we really are going to have to take on special interests in a way that I think optimistically we may, in fact, be ready to. We know we can competitive bid Medicare Advantage. We know we can purchase drugs more efficiently. We know there are a bunch of things we can do. And I would say this to all of the special interests, you'll be okay. You'll adjust. In 2008, when the ACA passed, every stock was down by like 50, 60%. They've had their best years since the ACA because they adjusted. And they'll adjust again. But we have to have the patient voice at the table, not just the special interest voice at the table. Now, before I'm going to go total communist on you for a second and say there's certain things maybe ought to be a public good. Like, say, insulin. Maybe ambulances. There's certain things that you look at. Our body produces them. Some people are unlucky. Their body doesn't produce it. That gives someone else the right to increase the prices by 100% every 3 or 4 years without changing the formula. Probably not. And finally, I think we have to ask ourselves, without putting too much stock in value-based care as a concept, because I've always sort of believed, payments aren't going to dictate high-quality care. Cultural leadership, focus on quality and commitment should do that, and payments ought to support and reward that. But having said that, if we really believe that where we ought to go is someplace that looks like quality-based capitation, then we ought to figure out how we get there a lot faster. One idea that was introduced 2 days ago, from someone who came out of the very left-leaning Trump administration, John Bartas, is that we ought to tell hospitals that they need to adopt value-based care or start to accept Medicare rates over some period of time. This is a Republican idea. I'm not saying it's endorsed by the Trump administration, but it's a thoughtful suggestion which says if you want to go faster, you got to get there. My final thing I'm going to close on is implementation. Some of you may know I got into government when the ACA crashed, and I contacted the Obama administration and came in and led the turnaround. Might be a good idea
to only pass laws that we're all committed to implementing together. Might be a good idea to agree that any law we pass is going to get it about 70 to 80% right, best case, and we got to be committed to fix the other 20 to 30%, or if we're not, we're not worthy of ourselves by letting a law be produced and then languish, as I think we've done with the ACA. We've got to be willing to put the corrections forward when we learn things. We've got to have people at the table who are going to be responsible for implementing these laws, and we've got to learn from them, because none of the things we do are going to work 100% right the first time. So those are my comments.